Hello, my amazing tribe. I'm excited to connect with you through this video. It's a pleasure to have you join us as we uncover the secrets of tooth whitening. Tooth whitening or tooth bleaching is the process of lightening the color of human teeth. Whitening is often desirable when teeth become yellowed over time for a number of reasons, and can be achieved by changing the intrinsic or extrinsic color of the tooth enamel. The chemical degradation of the chromogens within or on the tooth is termed as bleaching. Hydrogen peroxide is the active ingredient most commonly used in whitening products and is delivered as either hydrogen peroxide or carbamide peroxide. Hydrogen peroxide is analogous to carbamide peroxide as it is released when the stable complex is in contact with water. When it diffuses into the tooth, hydrogen peroxide acts as an oxidising agent that breaks down to produce unstable free radicals. In the spaces between the inorganic salts in tooth enamel, these unstable free radicals attach to organic pigment molecules, resulting in small, less heavily pigmented components. Reflecting less light, these smaller molecules create a whitening effect. There are different products available on the market to remove stains. For whitening treatment to be successful, dental professionals, dental hygienist or dentist should correctly diagnose the type, intensity and location of the tooth discoloration. Time exposure and the concentration of the bleaching compound determines the tooth whitening endpoint. As we venture forward, let's take a closer look at natural shade and its impact on our understanding. The perception of tooth color is multifactorial. Reflection and absorption of light by the tooth can be influenced by a number of factors, including specular transmission of light through the tooth, specular reflection at the surface, diffuse light reflection at the surface, absorption and scattering of light within the dental tissues, enamel mineral content, enamel thickness, dentine color, the human observer, the fatigue of the eye, the type of incident light, and the presence of extrinsic and intrinsic stains. Additionally, the perceived brightness of the tooth can change depending on the brightness and color of the background. The combination of intrinsic color and the presence of extrinsic stains on the tooth surface influence the color and thus the overall appearance of teeth. The scattering of light and absorption within enamel and dentine determine the intrinsic color of teeth, and because the enamel is relatively translucent, the dentinal properties can play a major role in determining the overall tooth color. On the other hand, extrinsic stain and color is the result of colored regions that have formed within the acquired pellicle on the enamel surface and can be influenced by lifestyle behaviors or habits. For example, dietary intake of tannin-rich foods, poor tooth brushing technique, tobacco products, and exposure to iron salts and chlorhexidine can darken the color of a tooth. With increasing age, teeth tend to be darker in shade. This can be attributed to secondary dentin formation and thinning of enamel due to tooth wear, which contributes to a significant decrease in lightness and increase in yellowness. Tooth shade is not influenced by gender or race. As we transition to the next segment, let's unravel the mysteries surrounding staining and discoloration and gain a fresh perspective. Tooth discoloration and staining is primarily due to two sources of stain, intrinsic and extrinsic. See Figure 2. In essence, tooth whitening primarily targets those intrinsic stains in which cannot be removed through mechanics such as a debridement, clean, or prophylaxis in the dental office. Below explains in depth the differences between the two sources of which contribute to such discoloration of the tooth's surface. Get ready for a captivating exploration as we unravel the layers of extrinsic staining and their profound significance. Extrinsic staining is largely due to environmental factors including smoking, pigments in beverages and foods, antibiotics, and metals such as iron or copper. Colored compounds from these sources are adsorbed into acquired dental pellicle or directly onto the surface of the tooth, causing a stain to appear. Dental plaque. Dental plaque is a clear biofilm of bacteria that naturally forms in the mouth, particularly along the gum line, and it occurs due to the normal development and defenses of the immune system. Although usually virtually invisible on the tooth surface, plaque may become stained by chromogenic bacteria such as actinomyces species. Prolonged dental plaque accumulation on the tooth surface can lead to enamel demineralization and formation of white spot lesions which appear as an opaque milk-colored lesion. The acidic byproducts of fermentable carbohydrates derived from high-sugar foods contribute to greater proportions of bacteria, such as Streptococcus mutans and Lactobacillus in dental plaque. High consumption of fermentable carbohydrates will promote demineralization and increase the risk of developing white spot lesions. Calculus, neglected plaque will eventually calcify and lead to the formation of a hard deposit on the teeth, especially around the gum line. The organic matrix of dental plaque and calcified tissues undergo a series of chemical and morphological changes that led to calcification of the dental plaque and therefore leading to the formation of calculus. The color of calculus varies and may be gray, yellow, black, or brown. The color of calculus depends on how long it has been present in the oral cavity for. It typically starts off yellow, and over time the calculus will begin to stain a darker color and become more tenacious and difficult to remove. Tobacco, tar in the smoke from tobacco products and also smokeless tobacco products tends to form a yellow-brown-black stain around the necks of the teeth above the gum line. The nicotine and tar in tobacco, combined with oxygen, turns yellow and over time will absorb into the pores of enamel and stain the teeth yellow. The dark brown to black stains along the gum line of the teeth are the result of the porous nature of calculus immediately picking up the stains from nicotine and tar. Betel chewing. Betel chewing produces blood-red saliva that stains the teeth red-brown to nearly black. The extract gel of betel leaf contains tannin, a chromogenic agent that causes discoloration of the tooth enamel. Tannin is also present in coffee, tea, and red wine and produces a chromogenic agent that can discolor teeth. Large consumptions of tannin-containing beverages stain the dental enamel brown due to the chromogenic nature. Certain foods, including curries and tomato-based sauces, can cause teeth staining. Certain topical medications, chlorhexidine antiseptic mouthwash binds to tannins, meaning that prolonged use in persons who consume coffee, tea or red wine is associated with extrinsic staining, i.e. removable staining of teeth. Chlorhexidine mouthwash has a natural liking for sulfate and acidic groups commonly found in areas where plaque accumulates, such as along the gum line, on the dorsum of the tongue and cavities. Chlorhexidine is retained in these areas and stain yellow-brown. The stains are not permanent and can be removed with proper brushing. Metallic compounds. Exposure to such metallic compounds may be in the form of medication or occupational exposure. Examples include iron black stain, iodine black, copper green, nickel green, and cadmium yellow-brown. Sources of exposure to metal include placing metal into the oral cavity, metal-containing dust inhalation, or oral administration of drugs. Metals can enter the bony structure of the tooth, causing permanent discoloration, or can bind to the pellicle causing surface stain. With that being said, let's now move on to removal of extrinsic staining. Extrinsic staining may be removed through various treatment methods. Say prophylaxis. Dental prophylaxis includes the removal of extrinsic staining using a slow-speed rotary handpiece and a rubber cup with abrasive paste, mostly containing fluoride. The abrasive nature of the prophy paste, as it is known, acts to remove extrinsic staining using the action of the slow-speed handpiece and the paste against the tooth. Adversely, the action of the rubber cup together with the abrasive nature of the paste removes around 1 micron of enamel from the tooth surface every time a prophylaxis is performed. This method of stain removal may only take place in the dental office. Microabrasion allows a dental professional to make use of an instrument which emits a power, water and compressed air to remove biofilm and extrinsic staining. This stain removal method can only be undertaken in a dental office, not at home. Toothpaste. There are many available on the market that implement both peroxide as well as abrasive particles, such as silica gel, to help remove extrinsic stains, while the peroxide acts on intrinsic staining. This method of stain removal may take place at home as well as in a dental office. As we transition to the next segment, let's unravel the mysteries surrounding intrinsic staining and gain a fresh perspective. Intrinsic staining primarily occurs during the tooth development, either before birth or at early childhood. Intrinsic stains are those that cannot be removed through mechanical measures such as debridement or a prophylactic stain removal. As the age of the person increases, the teeth can also appear yellow over time. Below are examples of intrinsic sources of stains: tooth wear and aging. Tooth wear is a progressive loss of enamel and dentin due to tooth erosion, abrasion, and attrition. As enamel wears down, dentin becomes more apparent and chromogenic agents are penetrated in the tooth more easily. The natural production of secondary dentin also gradually darkens teeth with age. Dental cavities, tooth decay. The evidence regarding caries tooth discoloration is inconclusive. However, the most reliable evidence suggests that caries lesion allows for exogenous agents to enter dentin and hence increased absorption of chromogenic agents, causing discoloration to the tooth. Restorative materials. The materials used during root canal treatments, such as eugenol and phenolic compounds, contain pigment that stain dentin. Restorations using amalgam also penetrate dentin tubules with tin over time, therefore causing dark stains to the tooth. Dental trauma, which may cause staining either as a result of pulp necrosis or internal resection. Alternatively, the tooth may become darker without pulp necrosis. Enamel hypoplasia. Enamel hypoplasia causes enamel to be thin and weak. It produces a yellow-brown discoloration and can also cause the enamel's smooth surface to be rough and pitted, which causes the tooth to be susceptible to extrinsic staining, tooth sensitivity, malocclusion, and dental cavities. The evidence regarding enamel hypoplasia is inconclusive. However, the most likely cause is infection or trauma caused to the primary dentition. Disturbances to the developing tooth germ during neonatal and early childhood stages, such as maternal vitamin D deficiency, infection, and medication intake, can cause enamel hypoplasia. Pulpal hyperemia. Pulpal hyperemia refers to inflammation of a traumatized tooth, which can be caused by a stimuli such as trauma, thermal shock, or dental cavities. Pulpal hyperemia is reversible and produces a red hue seen initially after trauma, which has the ability to disappear if the tooth becomes revascularized. Fluorosis. Dental fluorosis causes enamel to become opaque, chalky white, and porous. The enamel can break down and cause the exposed subsurface enamel to become mottled and produce extrinsic dark brown-black stains. Dental fluorosis occurs due to excessive ingestion of fluoride or overexposure to fluoride during the development of enamel, which usually occurs between the ages of 1 to 4. Fluoridated drinking water, fluoride supplements, topical fluoride toothpastes, and formula prescribed for children can increase the risk of dental fluorosis. Fluoride is considered an important factor in the management and prevention of dental cavities. The safe level for daily fluoride intake is 0.05 to 0.07 gOCD. Dentinogenesis imperfecta. Dentinogenesis imperfecta is a hereditary dentin defect associated with osteogenesis imperfecta, which causes the tooth to become discolored, usually blue or brown in color and translucent, giving teeth an opalescent sheen. The condition is autosomal dominant, which means that the condition runs in the family. Amelogenesis imperfecta. The appearance of amelogenesis imperfecta depends on the type of amelogenesis. There are 14 different subtypes and can vary from the appearance of hypoplasia to hypermineralization, which can produce different appearances of enamel, from white mottling to yellow-brown appearances. Tetracycline and minocycline. Tetracycline is a broad-spectrum antibiotic, and its derivative minocycline is common in the treatment of acne. The drug is able to chelate calcium ions and is incorporated into teeth, cartilage, and bone. Ingestion during the years of tooth development causes yellow-green discoloration of dentin visible through the enamel, which is fluorescent under ultraviolet light. Later, the tetracycline is oxidized and the staining becomes more brown and no longer fluoresces under UV light. Porphyria, a rare metabolic disorder in which the body fails to adequately metabolize porphyrins, which leads to accumulation or excretion of porphyrins into teeth. The excretion of porphyrins produces purple-red pigments in teeth. Hemolytic disease of the newborn. This disease occurs when a newborn's red blood cells are being attacked by antibodies from the mother caused by an incompatibility between the mother and baby's blood. This condition can produce green staining of teeth due to jaundice, which is an inability to excrete bilirubin properly. Root reception. Root reception is clinically asymptomatic, however, it can produce a pink appearance at the amelismental junction. Alkaptonuria, metabolic disorder which promotes the accumulation of homogenesic acid in the body and may cause brown color pigmentation in the teeth, gums, and buccal mucosa. Without further ado, let's move on to the topic of methods. Prior to proceeding to tooth whitening alternatives, it is advised that the patient comes into the dental office to have a comprehensive oral examination that consists of a full medical, dental, and social history. This will allow the clinician to see if there is any treatment that needs to be done, such as restorations to remove cavities, and to assess whether or not the patient will be a good candidate to have the whitening done. The clinician would then debride clean the tooth surface with an ultrasonic scaler, hand instruments, and potentially a prophy paste to remove extrinsic stains as mentioned above. This will allow a clean surface for maximum benefits of whichever tooth whitening method the patient chooses. Below we'll discuss the various types of tooth whitening methods, including both internal application of bleaching and external application through the use of bleaching agents. In the next segment, we'll be exploring in-office and its implications for our subject matter. Before the treatment, the clinician should examine the patient, taking a health and dental history including allergies and sensitivities, observe hard and soft tissues, placement and conditions of restorations, and sometimes X-rays to determine the nature and depth of possible irregularities. If this is not completed prior to the whitening agents being applied to the tooth surface, excessive sensitivity and other complications may occur. The whitening shade guides are used to measure tooth color. These shades determine the effectiveness of the whitening procedure, which may vary from 2 to 7 shades. These shades may be reached after a single in-office appointment, or may take longer, depending on the individual. The effects of bleaching can last for several months, but may vary depending on the lifestyle of the patient. Consuming tooth-staining foods or drinks that have a strong color may compromise effectiveness of the treatment. These include food and drinks containing tannins such as coffee, tea, red wines, and curry. In-office bleaching procedures generally use a light-cured protective layer that is carefully painted on the gums and papilla at the tips of the gums between the teeth to reduce the risk of chemical burns to the soft tissues. The bleaching agent is either carbamide peroxide, which breaks down in the mouth to form hydrogen peroxide, or hydrogen peroxide itself. The bleaching gel typically contains between 10% and 44% carbamide peroxide, which is roughly equivalent to a 3% to 16% hydrogen peroxide concentration. The legal percentage of hydrogen peroxide allowed to be given is %. Bleaching agents are only allowed to be given by dental practitioners, dental therapists, and dental hygienists. Bleaching is least effective when the original tooth color is grayish and may require custom bleaching trays. Bleaching is most effective with yellow discolored teeth. If heavy staining or tetracycline damage is present on a patient's teeth, and whitening is ineffective, tetracycline staining may require prolonged bleaching, as it takes longer for the bleach to reach the dentine layer. There are other methods of masking the stain. Bonding, which also masks tooth stains, is when a thin coating of composite material is applied to the front of a person's teeth and then cured with a blue light. A veneer can also mask tooth discoloration. In-chair whitening is faster and more effective in comparison to the take-home bleaching options. Some clinicians also make custom bleaching trays, which can take up to a week to create. After the whitening treatment is completed, the patient is able to use these trays for maintenance of their bleaching with at-home kits or for use with desensitizing products. Now, let's delve into the intricacies of light-accelerated bleaching and explore its various aspects. How or light-accelerated bleaching uses light energy which is intended to accelerate the process of bleaching in a dental office. Different types of energy can be used in this procedure, with the most common being halogen, LED, or plasma arc. Use of light during bleaching increases the risk of tooth sensitivity and may not be any more effective than bleaching without light when high concentrations of hydrogen peroxide are used. A 2015 study showed that the use of a light activator does not improve bleaching, has no measurable effect, and rather is likely to increase the temperature of the associated tissues, resulting in damage. The ideal source of energy should be high energy to excite the peroxide molecules without overheating the pulp of the tooth. Lights are typically within the blue light spectrum as this has been found to contain the most effective wavelengths for initiating the hydrogen peroxide reaction. A power bleaching treatment typically involves isolation of soft tissue with a resin-based, light-curable barrier, application of a professional dental-grade hydrogen peroxide whitening gel % hydrogen peroxide, and exposure to the light source for minutes. Recent technical advances have minimized heat and UV emissions, allowing for a shorter patient preparation procedure. For any whitening treatments, it is recommended that a comprehensive examination of the patient is done, including the use of radiographs to aid in the diagnosis of the current condition of the mouth, including any allergies that may be present. The patient will need to have a healthy mouth and free of periodontal disease or cavities and to have had a debridement clean done to remove any tartar or plaque build-up. It is recommended to avoid smoking, drinking red wine, eating or drinking any deeply colored foods after this, as the teeth may stain considerably straight after treatment. In this part of the video, we'll be diving deep into nanoparticle catalysts for reduced hydrogen peroxide concentration and unraveling its profound impact. A recent addition to the field is new light-accelerated bleaching agents containing lower concentrations of hydrogen peroxide with a titanium oxide nanoparticle-based catalyst. Reduced concentrations of hydrogen peroxide cause lower incidences of tooth hypersensitivity. The nanoparticles act as photocatalysts, and their size prevents them from diffusing deeply into the tooth. When exposed to light, the catalysts produce a rapid, localized breakdown of hydrogen peroxide into highly reactive radicals. Due to the extremely short lifetimes of the free radicals, they are able to produce bleaching effects similar to much higher concentration bleaching agents within the outer layers of the teeth where the nanoparticle catalysts are located. This provides effective tooth whitening while reducing the required concentration of hydrogen peroxide and other reactive byproducts at the tooth pulp. In the upcoming section, we'll be dissecting internal bleaching and exploring its implications in greater detail. Internal bleaching is a process which occurs after a tooth has been endodontically treated. This means that the tooth will have had the nerve of the tooth extirpated or removed through a root canal treatment at the dentist or by a specialist endodontist. Internal bleaching is often sought after in teeth which have been endodontically treated, as tooth discoloration becomes a problem due to the lack of nerve supply to that tooth. It is common to have this internal bleaching done on an anterior tooth, a front tooth that you can see when smiling and talking. A way around this is by sealing off the bleaching agent inside the tooth itself and replacing it every few weeks until the desired shade has been achieved. The amount of time between appointments varies from patient to patient and with operator preference until the desired shade has been achieved. Even though this is a great option, the disadvantage of this treatment is a risk of internal root resorption of the tooth that is being internally bleached. This may not occur in every patient or every tooth, and its occurrence is difficult to determine prior to completing the treatment. In the next phase, we'll be immersing ourselves in the realm of at-home and exploring its real-world applications. At-home tooth whitening products are available from dentists or over-the-counter OTC. At-home whitening methods include over-the-counter strips and gels, whitening rinses, whitening toothpastes, and tray-based tooth whiteners. OTC products can be used for milder cases of tooth staining. Home-based bleaching following manufacturer's instructions results in less tooth sensitivity than in-office bleaching. As we transition, let's shed light on strips and gels and its relevance to our ongoing exploration. The plastic whitening strips contain a thin layer of peroxide gel and are shaped to fit the buccal-labial surfaces of teeth. Many different types of whitening strips are available on the market after being introduced in the late years. Specific whitening strip products have their own set of instructions, however the strips are typically applied twice daily for 30 minutes for 14 days. In several days, tooth color can lighten by 1 or 2 shades. The tooth whitening endpoint does depend on the frequency of use and ingredients of the product. Whitening gels are applied onto the tooth surface with a small brush. The gels contain peroxide and are recommended to be applied twice a day for 14 days. The tooth whitening endpoint like that of the whitening strips. Let's now turn our attention to rinses and examine its role within the larger context. Whitening rinses work by reaction of the oxygen sources such as hydrogen peroxide within the rinse and the chromogens on or within the tooth. It is recommended to use twice a day, rinsing for 1 minute. To see an improvement in shade color, it can take up to 3 months. Let's now turn our attention to toothpastes and examine its role within the larger context. Whitening toothpastes differ from regular toothpastes in that they contain higher amounts of abrasives and detergents to be more effective at removing tougher stains. Some whitening toothpastes contain low concentrations of carbamide peroxide or hydrogen peroxide which help lighten tooth color, however they do not contain bleach sodium hypochlorite. With continuity of use over time, tooth color can lighten by 1 or 2 shades. As we enter this new phase, let's analyze tray-based from different angles and evaluate its significance. Tray-based tooth whitening is achieved by wearing a fitted tray containing carbamide peroxide bleaching gel overnight or for 2 to 4 hours a day. If manufacturer's instructions are followed, tooth whitening can occur within 3 days and lighten teeth by 1 or 2 shades. This type of tooth whitening is available over the counter and professionally from an oral health professional. In this section, we'll be shedding light on baking soda and its impact on our understanding of the subject. Baking soda is a safe, low abrasive, and effective stain removal and tooth whitening toothpaste. Tooth whitening toothpaste that have excessive abrasivity are harmful to dental tissue, therefore baking soda is a desirable alternative. To date, clinical studies on baking soda report that there have been no reported adverse effects. It also contains acid buffering components that makes baking soda biologically antibacterial at high concentrations and capable of preventing growth of Streptococcus mutans. Baking soda might be useful for cavities-prone patients, as well as those who wish to have whiter teeth. With our foundation established, it's time to explore pens and its relevance to our overarching theme. Whitening pens are a convenient way to touch up any dental surface. The plastic, convenient, tube contains a bleaching gel that can be easily applied in hard-to-reach spots. In order to work, the gel needs to stay on the tooth surface for around minutes. Get ready to immerse yourself in the world of indications as we examine its impact and relevance. Tooth whitening may be undertaken for a variety of reasons, but whitening may also be recommended to some individuals by dental professionals. Intrinsic tooth staining, aesthetics, dental fluorosis, endodontic treatment, internal bleaching, tetracycline staining. With our curiosity piqued, let's embark on a dedicated exploration of contraindications and its fascinating intricacies. Some groups are advised to carry out tooth whitening with caution as they may be at higher risk of adverse effects. Patients with unrealistic expectations, allergy to peroxide, pre-existing sensitive teeth, cracks or exposed dentine enamel development defects, acid erosion, receding gums, gingival recession and yellow roots, sensitive gums, defective dental restorations, tooth decay. White spot decalcification may be highlighted and become more noticeable directly following a whitening process, but with further applications the other parts of the teeth usually become more white and the spots less noticeable. Active periapical pathology and treated periodontal disease pregnant or lactating women, children under the age of 16. This is because the pulp chamber, or nerve of the tooth, is enlarged until this age. Tooth whitening under this condition could irritate the pulp or cause it to become sensitive. Younger people are also more susceptible to abusing bleaching. Persons with visible white fillings or crowns. Tooth whitening does not change the color of fillings and other restorative materials. It does not affect porcelain, other ceramics, or dental gold. However, it can slightly affect restorations made with composite materials, cements, and dental amalgams. Tooth whitening will not restore color of fillings, porcelain, and other ceramics when they become stained by foods, drinks, and smoking, as these products are only effective on natural tooth structure. As such, a shade mismatch may be created as the natural tooth surfaces increase in whiteness and the restorations stay the same shade. Whitening agents do not work where bonding has been used, and neither is it effective on tooth-colored filling materials. Other options to deal with such cases are the porcelain veneers or dental bonding. Individuals with poor oral hygiene. Moving forward, we'll be taking a closer look at risks. Some of the common side effects involved in teeth whitening are increased sensitivity of the teeth, gum irritation, and extrinsic teeth discoloration. In the next phase, we'll be immersing ourselves in the realm of hypersensitivity and exploring its real-world applications. The use of bleach with extremely low levels in the tooth whitening procedure may lead to hypersensitive teeth, as it causes the dentinal tubules to open. Exposure to cold, hot, or sweet stimuli may further exacerbate the intensity of the hypersensitive response. Amongst those who receive in-office whitening treatment, between 67 and 78% of the individuals experience sensitivity after the procedure where hydrogen peroxide and heat is utilized. Although it varies from person to person, sensitivity after whitening treatment can last up to days. Potassium nitrate and sodium fluoride in toothpastes are used to ease discomfort following bleaching. However, there is no evidence to suggest that this is a permanent method to eradicate the issue of hypersensitivity. In the upcoming section, we'll be shining a light on irritation of mucous membranes. Hydrogen peroxide is an irritant and cytotoxic. Hydrogen peroxide with concentrations of 10% or higher can cause tissue damage, be corrosive to mucous membranes, and cause burning sensation to the skin. Chemical burns can commonly occur whilst bleaching. Irritation and discoloration of the mucous membranes may occur if a high concentration of oxidising agent comes into contact with unprotected tissue. Poorly fitting bleaching trays are amongst the most common reasons for chemical burns. The temporary burning induced by whitening treatments can be reduced by using custom-made plastic trays or night goods provided by the dental professional. This prevents the leakage of solution onto the surrounding mucosa. Let's now turn our gaze towards uneven results and explore the fascinating connections it has to offer. Uneven results are quite common after bleaching. Consuming less foods and drinks that cause surface staining of teeth can contribute to attaining a good result from tooth whitening. In the upcoming portion, we'll be dissecting return to original pre-treatment shade to gain a comprehensive understanding of its implications. Nearly half the initial change in color provided by an intensive in-office treatment, i.e., 1-hour treatment in a dentist's chair, may be lost in 7 days. Rebound is experienced when a large proportion of the tooth whitening has come from tooth dehydration, also a significant factor in causing sensitivity. As the tooth hydrates, tooth color rebounds back toward where it started. Let's now shift our focus to overbleaching and explore the ways in which it shapes our perspective. Overbleaching, more often known as the bleach defect, occurs among treatments that promise a large change over a short period of time, e.g., hours. Overbleaching can emit a translucent and brittle appearance. Now, let's redirect our focus towards damage to enamel and discover its significance in our narrative. Teeth enamel can have an adverse negative effect by whitening treatment. Evidence from studies show that carbamide peroxide present in whitening gels can damage the enamel surface. Although this effect is not as damaging as phosphoric acid etch, the increased irregularity of the teeth surface makes the teeth more susceptible to extrinsic staining, thus having an increased detrimental effect on the aesthetics. The increased porosity and changes in surface roughness may have an impact on the formation of supra- and subgingival plaque, thus increasing the adhesion of bacterial species such as Streptococcus mutans and Streptococcus sobranis, significant contributors to dental cavities. Dental restorations are susceptible to unacceptable color change even when using the home-based systems. As we embark on the next leg of our journey, let's unpack the layers of weakened dentin and examine its core elements. Intracranial bleaching is a tooth whitening method that uses 30% more hydrogen peroxide. Such tooth whitening methods can weaken the mechanical properties of dentin and could potentially lead to severe tooth sensitivity. Now, let's shift our focus to effects on existing restorations and embark on an intellectual exploration of its various dimensions. Dental restorations are susceptible to unacceptable color change even when using the home-based systems. Ceramic crowns. Aggressive bleaching can chemically react with ceramic crowns and reduce their stability. Dental amalgam exposure to carbamide peroxide solutions increase mercury release for 1 to 2 days. The release of amalgam components is said to be due to active oxidation. This increase in amalgam mercury release is proportional to the concentration of carbamide peroxide. Resin composite bond strength between enamel and resin-based fillings become weakened. Many studies have found that 10–16% carbamide peroxide tooth bleaching gels containing approximately % hydrogen peroxide leads to an increase in the surface roughness and porosity of composite resins. However, the saliva may exert a protective effect. In addition, changes in the reflectance of the composite have been analyzed following whitening with high concentration 30–35% hydrogen peroxide. This suggests that tooth whitening negatively impacts composite resin restorations. Glass ionomer and other cements studies suggest that solubility of these materials may increase. The time has come to unravel the secrets behind bleachorexia and gain a deeper understanding. Bleachorexia is the term that is used to describe an individual that develops an unhealthy obsession with teeth whitening. This condition is similar to body dysmorphic disorder. The characteristics of bleachorexia are the continuous use of whitening products even though the teeth cannot possibly become whiter, despite the provision of repeated treatment. A person with bleachorexia will continually seek out for different whitening products. Hence, it is recommended that a target shade is agreed upon before starting the treatment procedure to help with this problem. As we enter this new chapter, let's navigate the complexities of home teeth whitening risks and unravel its multifaceted nature. The use of personalized home whitening trays is a patient-administered therapy that is prescribed and dispensed by a dentist. Patients need to actively participate in their treatment and follow the guidelines given by the dentist accurately. Erratic or inaccurate use of the bleaching trays could cause harm to the patient, such as blistering or sensitivity of the teeth and the surrounding soft tissue. Inconsistent use of the bleaching trays can lead to the slowing and irregularity of the whitening process. Some patients with a substantial gag reflex may not be able to tolerate the trays and would need to consider other methods of teeth whitening. As we progress through this video, let's now turn our gaze towards other risks. Evidence suggests that hydrogen peroxide might act as a tumor promoter. Although cervical root resection is more evidently observed in thermocatalytic bleaching methods, intracranial internal bleaching may also lead to tooth root resection. Moreover, severe damage to intracranial dentin and tooth crown fracture can occur due to this bleaching method. However, the International Agency of Research on Cancer (IARC) has concluded that there is insufficient evidence to prove that hydrogen peroxide is a carcinogen to humans. Recently, the genotoxic potential of hydrogen peroxide was evaluated. The results indicated that the oral health products that contain or release hydrogen peroxide up to 3.6% will not increase the cancerous risk of an individual, hence, it is safe to use in moderation. Brace yourself for an enlightening exploration of maintenance as we dive into its profound implications. Despite achieving the results of treatment, stains can return within an initial couple of months of treatment. Various methods may be employed to prolong the treatment results, such as brush or flush out mouth with water after eating and drinking floss to remove plaque and biofilms between the teeth. Take special care during the first 2 days. The first hours after the whitening procedure is seen as the most crucial period in which you must protect for your teeth the most. Hence, it is vital that non-staining drinks or foods are eaten during this time, as enamel is prone to adhere to stains. Drink fluids that may cause staining through a straw depending on the method used to whiten the teeth. Retreatment every 6 months or after a year may be required. If an individual is a smoker or they consume beverages with the capacity to stain, regular retreatments would be required. Prepare yourself for an in-depth analysis of history in this section. Teeth whitening remedies have been present since ancient times. Despite seeming absurd, some methods were somewhat effective in their results. Ancient Roman dentists believed in using urine with goat milk to make their teeth look whiter. Pearly white teeth symbolized beauty and marked wealth. In our medicine system, oil pulling was used as an oral therapy. For this process today, swish coconut or olive oil in your mouth for up to 20 minutes each day. In the late 17th century, many people reached out to barbers, who used a file to file down the teeth before applying an acid that would, in fact, whiten the teeth. Although the procedure was successful, the teeth would become completely eroded and more prone to becoming decayed. Guy de Chauliac suggested the following to whiten the teeth. Clean the teeth gently with a mixture of honey and burnt salt to which some vinegar has been added. In 1877, oxalic acid was proposed for whitening, followed by calcium hypochlorite. In the late years, mouthwash containing pyrazone ether peroxide was found to reduce cavities while providing a whiter appearance to the teeth. By years and years, ether and hydrogen peroxide gels were used to whiten vital teeth, whereas non-vital teeth were whitened using pyrazone and sodium perborate. In the late years, William Klusmeyer, an orthodontist from Fort Smith, Arkansas, introduced the custom tray bleaching. However, it was not until 1989 that Haywood and Heyman published an article in support of this method. Carbamide peroxide with a shelf life of 1 to 2 years, as opposed to hydrogen peroxide with a shelf life 1 to 2 months, was seen as a more stable agent for whitening teeth. In this part of the video, we'll be diving deep into society and culture and unraveling its profound impact. Teeth whitening has become the most promoted and mentioned methodology in cosmetic dentistry. In excess of 100 million Americans brighten their teeth using different methods, spending $15 billion in 2010. The U.S. Food and Drug Administration only endorses gels that are under 6% hydrogen peroxide or 16% or less of carbamide peroxide. The Scientific Committee on Consumer Safety of the EU consider gels containing higher fixations can be dangerous. As per European Council guidelines, only a certified dental professional can lawfully give tooth whitening products utilizing % hydrogen peroxide, provided the patient is 18 years of age or older. In 2010, the UK General Dental Council became concerned of the risk to patient safety from poor quality tooth whitening being carried out by untrained or poorly trained staff. A public attitudes survey conducted by the GDC showed that 83% of people support policies of regulating tooth whitening to protect patient safety and prosecuting illegal practice. A group of dental professionals and associations called the Tooth Whitening Information Group (TWIG) was founded to advance protected and beneficial tooth whitening information and assistance to the general population. Reports can be made to the TWIG through their website with respect to any individual giving unlawful tooth whitening services, or if an individual has personally undergone treatment done by a non-dental professional. In Brazil, all whitening items are classed as cosmetics degree 2. There are worries that this will bring about increasing abuse of whitening products, and thus there have been calls for re-releases. According to research, tooth whitening can produce positive changes in young participants' oral health-related quality of life, vocal in aesthetic areas such as smiling, laughing, and showing teeth without embarrassment. However, its main side effect, tooth sensitivity, negatively affects quality of life. If you found this video helpful, give it a like and share it with someone who might benefit from it.